start.
Good afternoon, everyone. My name is Naisha Paul.
I'm Chloe Valerie.
My name's Ben Abe.
And I'm Seth Brown.
And for our senior research project, my group and I decided to focus in on the topic of cardiac arrest. Okay? And through further research and investigation of the topic, we were actually able to come up with our own project. And we call it the Rapid Response Automated Epinephrine Injector, also known as RED. And with this innovation, we hope to combat some of the main issues affiliated with cardiac arrest protocol.
So how many of you here know someone, maybe a friend or family member, that has been affected by cardiac arrest? As you can see, the chances are fairly high. So what is cardiac arrest? Cardiac arrest is a sudden loss of electrical and or mechanical function in the heart. There are 4 different rhythms associated with cardiac arrest. The first 2 are pulseless ventricular tachycardia and ventricular fibrillation. This is when the lower chambers of the heart quiver and do not pump blood through the body properly. Next is asystole. This is when there's no heart function at all. The last is pulseless electrical activity, and this is where there is electrical activity but no mechanical. So when blood is not pumping through the body, that means there's a lack of oxygen reaching vital organs. This can eventually result in death.
Cardiac arrest is one of the leading causes of death in the United States today. More than 420,000 cases of out-of-hospital cardiac arrest occur per year. About half the number of those cases actually occur in a hospital with a survival rate of 7 to 26%. By the year 2030, it is projected that there will be over 23.6 million cases of cardiac arrest in the United States alone. As you can see in this pie graph in the yellow, sudden cardiac arrest accounts for nearly half of the associated deaths among the listed diseases, including Alzheimer's, assault with firearms, diabetes, HIV, and even suicides.
So when addressing cardiac arrest, the first step that paramedics will take is cardiopulmonary resuscitation, also known as CPR. CPR involves the use of an automated external defibrillator, chest compressions, and the use of epinephrine. Epinephrine is administered every 3 to 5 minutes, and chest compressions are done at 30 compressions and 2 rescue breaths. CPR is not stopped until either the patient shows no signs of life or they show signs of life.
As mentioned in the prior slide, administering epinephrine is a vital step in addressing cardiac arrest. Epinephrine is a hormone secreted by the adrenal glands and is known as adrenaline. It is used in the fight or flight response as it increases blood pressure, heart rate, and strength. It is the primary drug used in pulseless arrest algorithm and is known to increase arterial blood pressure and coronary perfusion. So, epinephrine works on 2 different receptors in the heart. The beta receptors, which lead to vasodilation of the blood vessels, and the alpha receptors, which lead to vasoconstriction of the blood vessels. So when epinephrine binds to the beta receptors in the heart, a cascade of events occur where G proteins are activated, which activates the adenine cyclase enzyme, which converts this ATP molecule into the C-AMP molecule, creating vasodilation effects of the blood vessel. When alpha receptors are activated by the epinephrine through binding, a cascade of events occur which activate the protein kinase enzyme, which phosphorylates the contractile membranes and channels in the heart that control the heart functions. When this happens, calcium currents are created, which increase the beating of the heart and muscle contractility. So you may be wondering how this all works and how it leads to vasoconstriction of the blood vessels. Well, during cardiac arrest, epinephrine is injected in a large dose. Therefore, vasoconstriction effects dominate over the vasodilation effects in the heart. This then leads to enhanced myocardial and cerebral blood flow throughout the body and increased blood pressure through all the vessels within the body.
Okay. As far as the epinephrine administration is actually concerned, there are 3 main methods, and all are done within a 3 to 5 minute interval. The first one I'd like to introduce you to is intravenously, which I'm sure most of you are familiar with. IV actually consists of either a central line or a peripheral line. The central line goes directly into the chest and goes into the heart for delivery of epinephrine. The peripheral line goes into the arm and then takes a different route and goes into the heart for the epinephrine delivery. There's also endotracheal, and while this one isn't as favored due to other issues, which I'll address later, this one goes straight into the trachea, either through the nose or mouth, and then ensures a delivery straight into the alveoli of the lungs. And then my last one that I'd like to introduce you to is IO, which we also call intraosseous. And this is the approach we took for our mechanism that we'll further discuss later in the PowerPoint. And we decided on this one because this one's the easiest one. It goes directly into the bone, by the way. And it's the quickest route, it's easy, and it takes no skill at all to do.
Scientists from the Beth Israel Deaconess Medical Center actually conducted a study following the administration of epinephrine and the chances of the patient's survival. The study followed over 25,000 patients from over 570 different hospitals. As you can see in the graph, the chances of the patient's survival substantially decreases as the time of administration of epinephrine increases.
Okay, so with our mechanism, we hope to combat not too many issues, but just the main ones that we've talked about. We want to combat human error because we don't want to lose any extra time. And with IV, there's issues with collapsed veins and arteries, and we don't want to waste time trying to address all that. So we want to eliminate that first. And then we also want to correct any kind of incorrect time intervals with time that might be lost throughout the entire protocol. And then we also want to correct anything that has to do with the paramedics potentially forgetting to administer the epinephrine. And so we took that into consideration with our innovation by applying a system that actually sets off an alarm to notify the firefighters or whoever may be addressing the situation at the time to administer the epinephrine.
So the innovation that we are proposing in this project is the rapid response automated epinephrine injector. Now the primary function of the mechanism is actually going to act as a cycler, in which it's going to contain 8 tubes of 1 milligram per epinephrine for 1 to 10,000 concentration. The mechanism will also have an intraosseous tube which will be injected into the patient's serum via an IO drill. And once the tube is emptied, the mechanism is then going to cycle to the next tube of epinephrine, in which are then prepped for administration. So this is just a blown up version of what our mechanism actually is going to look like. As you can see, the automated cycler contains 8 tubes, which will cycle around the intraosseous tubing. We have a hub right here, which has been dispatched and detached into the patient's serum via an IO drill.
So for our group's hypotheses, our null hypothesis is that although the rapid response automated epinephrine injector ensures the epinephrine will be administered within a 3 to 5 minute time interval, there will be no change in the return of spontaneous circulation with the cardiac arrest patient. For our alternative, which we hope to prove true, the rapid response automated epinephrine injector will administer epinephrine within the standard time interval. Therefore, it will increase the chance of return of spontaneous circulation in the cardiac arrest patient.
So now that you've seen the visual of our mechanism, you will now understand how it works. The EMT personnel will use the interosseous drill to create a universal access point into the sternum. The hub will then be dispatched into the sternum and detached from the drill. When this happens, the tubing that connects to the cycler pack will be attached to the hub so the cycler can start. The EMT personnel will press the inject button to start the cycler, and a timer will go off after 4 minutes of the process. This process will repeat itself, and the EMT personnel will continue pressing the eject button every 4 minutes when it notifies the EMT personnel until proved no longer needed, and they will then press the stop button.
So you may be wondering, what are some benefits of this innovation? First off, paramedics will have one less thing to worry about in a stressful situation. The 8 tube cycles will be interchangeable, so the base of our innovation will be able to be reused as many times as possible. It will be small, portable, and easy to use, and overall it will increase the chance of survival among cardiac arrest patients.
Throughout this actual process, we were able to go and investigate and talk to different professionals in the emergency medicine field. And all of our research actually landed us in Myersville, Maryland. And we were able to talk to an EMS specialist by the name of Jesse McKittrick. And after sitting down and talking to Jesse McKittrick, he was actually able to give us some good insight and professional aspect kind of thing. And he told us that while this idea would be a very good idea, it's beneficial that they've used it in the field, that it might be some things we might run into would be funding it or paying for it, seeing as this is still a work in progress. But all in all, we got positive feedback from everyone that we did speak to, and we're very thankful for it. As previously mentioned, I'm sorry, you're gonna get tired of me. As previously mentioned, we were able to talk to other tech areas and work with other areas, and we were able to work with CGDA downstairs, and they were able to help us put together an animation to help you all further visualize what we're talking about.
So as you can see here, there is actually a patient that is suffering from cardiac arrest and is currently being prepped for the CPR protocol. The EMS personnel is now palpating for a radial pulse within the patient. And now the EMS personnel is engaging in chest compressions. We can now see that the EMS personnel is dispatching and detaching the IO pump into the patient's sternum. And now you will get to visually see our mechanism at work. As you can see, the mechanism is now cycling the different tubes of epinephrine. Now, of course, this is in elapsed time. It would never be going this fast.
So, through our research and exploration of our topic regarding cardiac arrest, our innovation, the Rapid Response Automated Epinephrine Injector, which uses the interosseous drill to create a universal access point into the sternum and works on a timing mechanism to notify the EMT personnel, will successfully increase the return of spontaneous circulation.
So in conclusion, our group will accept our alternative hypothesis, which was the rapid response automated epinephrine injector will administer the epinephrine within their standard time interval. Therefore, it will increase the return of spontaneous circulation in a cardiac arrest patient. We want to thank you all for coming out to see our presentation today, and we will be happy to answer any questions that you have.
Are there any other examples of the IO with the drill and everything being used on a patient in the field that you can give me?
They're in military personnel, they use an actual sternum induction through.
It's called a bone injection gun that they use in the military, and it's not quite the same as the drill. It's kind of just like, it almost looks like a pen, and they just put it on the sternum and like push pressure down in to put it to.
And what are they injecting in that case? Is it epinephrine?
It could just be an access point for any type of medicine.
Okay.
Yeah.
So just to create.
Yeah.
So why did you take the drill then? Because then you could establish.
It was very quick and easy.
Yeah.
So when you were determining what you wanted to do, I have an idea what you were thinking, but why didn't you have that just automatically inject the epinephrine?
Well, after talking to Mr. Jesse McTurk, he had stated that it would be better if we would have an eject button or a stop button, because if the EMT personnel would decide that it needed to be stopped, or if he wanted to wait a little longer, then it was up to the EMT's decision.
Okay. So you wanted to make sure that you had a medical professional watching it to see if they really needed to inject it?
Yes.
Yes.
Okay, that makes sense. Thanks.
Is there any standard dose for epinephrine injection during CPR, or do we have to account for dose?
The standard dose is actually going to be 1 milligram per 1 to 10,000 concentration of epinephrine. Anywhere beyond that, as Naisha said, endotracheal is going to use double that. It's going to be 2 milligrams going down the patient's trachea. But other than that, they usually stick to 1 milligram.
Even if you have a child or you have a tiny person or a person.
Correct.
Correct.
I know you mentioned before, like the price, like not having an idea, but like what would be like the price range for this sport? Because I just know like being in a firehouse, like a lot of the stuff they have there, you know, they try to keep it within the budget. So like, would it be something that like all companies would be able to access, or would it be more of over time, more and more companies would be able to have on their ambulances?
I think we'd start small and like with local areas and like hospitals and like little areas, and then from there grow on it as we like see progress and how well the innovation actually does work in the field.
Yeah.
I would think with that kind of injection, you would be concerned about possible infections forming. Have you looked into that at all?
Yeah, I mean, the way we saw it, we wanted it to be as sterile as possible. We wanted to make sure that there wasn't going to be any possible infections that would intrude into the patient system. As far as actually the infections ranging into the patient, there's really no accountability on how we do it.
At this point, we would be more concerned about bringing the person back from the cardiac arrest and then worry about an infection later. I
Yeah.
think.
How much pain does your device create? Like, is this a painful procedure?
Actually, we have watched many videos of the sternal injection of like people like just they're alive and awake, and they honestly, like, didn't even feel it. It was kind of, they said that it was just like a regular shot into your arm. The only thing that was different is the pressure into the bone, but other than that, they said it was like, it wasn't anything different than a regular injection.
That,
It's more-
and if it's like,
It's more of a discomfort than it is a pain, I think.
Yeah.
You were told actually the most painful part was the administering the actual epinephrine for the patient's body.
and I mean, if they're unconscious, I'm sure that's the least of their worries. We're just trying to keep them alive.
Did you explore any other options of placement rather than in the sternum, just to combat, you might interfere with the CPR?
Yes, we actually looked at the humeral joint and then also the tibial joint. And that was another option. Our drill can be used in those options. We just focused on the sternum, as there was many studies showed that it showed the quickest injection into the heart. So.
What would you do at the time that it was?
Well,
Go ahead,
we'd have to,
Lars.
we'd have to go back to the old.
Action, stop.
IVX.
How does the drill work?
How does the drill work?
Yeah,
It's literally the way a drill would work. You're literally like spinning a needle into the patient's system.
If you want to go back, there's like, if you look at the drill, there's like the button that you press, which then starts like the circulating to go into the body.
It goes in like a needle first, and then once the paramedic reaches the bone, they then like
There's like a
press the
little
button.
button, and then this is the hub, and it will circulate into the sternum.
What are side effects of your innovation? And what would be some type of side effects that could possibly come from your innovation?
The primary side effect that I was exploring was actually neurological defects from epinephrine, since that was a prevalent issue in my research. However, I did find this study that was actually presented by Michi, but what he was saying was actually that the neurological aspects actually, epinephrine will actually benefit the neurological aspects instead of take away in negative standpoints. Any other questions?
Okay, thank you.